Traditional anatomical study separates the body into isolated regions, examining the organs of the chest or abdomen as independent subjects. This method obscures a critical physiological reality. These organs are linked by a continuous textural matrix. The methodology of integral anatomy reevaluates these membranes. Rather than treating them as regional borders, it observes them as a continuous, interconnected web that spans the entire body. These tissues are visceral fasciae, the repeating structural units of the mesotheliae. Mesotheliae are specialized membranes that line the body's internal cavities and cover the organs, including the pleura, pericardium, and peritoneum. Localized scars within this matrix become mechanical disruptions. These pathological adhesions halt the natural kinematic limit cycles, the repetitive inherent physical movements of the organs. To treat these immobilities effectively, clinicians must first decode the precise mechanical layers that govern normal visceral sliding. This schematic shows how the fascial matrix organizes into a three-layer structural model, repeating across the cranial, thoracic, cardiac, and abdominal spaces. The first layer is the fibrous outermost layer, acting as a stabilizing container defining the boundaries of the internal cavity. Inside sits the second layer, the parietal serous layer, which forms the inner wall coating the internal surface of the container. The third layer is the visceral serous layer, reflecting off the parietal wall to form an enveloping balloon wrapped directly over the organ. Physiological function is dependent on the structural integrity and the frictionless mechanical interplay between these three specific layers. A degree of fixation between these layers is mechanically normal. The parietal serous layer must anchor to the outermost fibrous layer to stabilize the cavity. This image shows the parietal peritoneum of the abdomen. The yellowish tissues along the midline represent the normal fibrous fixation anchoring the parietal peritoneum to the overlying transversalis fascia. Despite this firm anchor, these remain distinct structural layers. In a laboratory setting, while a scalpel is required at the midline, the rest of the shared surface can be manually peeled apart. Compare that to the visceral peritoneum, shown here wrapping the hepatic flexure of the colon. This layer roots deeply into the organ's parenchymal connective tissue. Parenchymal tissue refers to the functional parts of an organ, as opposed to its structural support. These deep connections mean the visceral layer cannot be peeled away. It serves as the intrinsic skin of the organ. Any attempt to physically differentiate it will merely shred the surface tissue. Understanding the difference between a peelable wall and an intrinsic skin is the prerequisite for identifying when an adhesion becomes pathological. In a healthy system, the visceral and parietal layers form a sliding surface. They move against each other constantly to accommodate respiration and digestion. A pathological adhesion is a fixed connection between these surfaces. The movement halts and surrounding tissue warps under tension. This is distinct from a ligamentous distortion. Visceral ligaments are natural folds of tissue that tie organs together. A distortion alters their length, while an adhesion glues sliding surfaces into a single mass. Inflammatory disease processes are a primary cause of these adhesions. This image shows the inferior margin of the liver physically bound to the greater omentum, a result of fibrous aggregations that form as the tissues heal. These fixations can also anchor free-floating structures to the cavity walls. Here, a fatty epiploic appendage of the colon has abnormally adhered to the posterior parietal peritoneum, altering the local biomechanics. Any fibrous disruption of this natural slide starves the organ of its required mobility and diminishes its physiological capacity. Surgical intervention is a common etiology for adhesions. Observation in the laboratory suggests that exterior surgical scars reliably predict interior fascial scarring. As surgical incisions heal, the body aggregates fibrous matter. This creates multidirectional scar tissue that pins delicate mesothelial layers together and destroys localized elasticity. This image shows the results of an open-heart surgery. Fibrous adhesions have bridged the gap between the visceral and the parietal pericardium, fusing the layers into a single unit. This initial surgical fixation often initiates a biomechanical cascade known as progressive adhesion. Here, an adhesion at the margins of the lung is being peeled from the mediastinal pleura. The original scar limited the organ's motion, creating a cloud of stillness that caused adjacent, normally sliding tissues to freeze and adhere as well. Immobility acts as a pathogen. A localized surgical trauma can progressively transform a dynamic, sliding visceral space into a rigid block. When a practitioner palpates a restricted visceral mass, the intuitive response is to directly and mechanically break the adhesion. During gross dissection in a laboratory setting, pulling these adhered layers apart manually is an effective way to differentiate the local anatomy. However, applying this force to living, innervated mesothelia creates microtraumas. Innervated tissues are those supplied with nerves that transmit sensory and motor signals. This wounding triggers an inflammatory response. In a living body, tearing the tissue risks locking the patient into a cycle of worsening fixations as the inflammation produces new fibrous threads. An alternative strategy involves facilitating movement toward the normal range of motion with gentle traction. By leveraging several deep breath cycles, a practitioner can encourage the tissue to lengthen without the trauma of acute mechanical failure. By introducing structural torsion with coached pose cycles, the therapist increases the demand for gliding between sliding surfaces. This repetitive expansion can induce the dissolution of adhesions over time. Restoring visceral kinematics requires abandoning the instinct to tear tissue. Reiterating movement cycles allows fascia to progressively return to perpetual glide.